Now we come to Belmont. Belmont is the story of Tuskegee, I think, but the National Research Act was signed into law in '74 and that commission came into being. And one of the responsibilities of this commission was to identify, two of the responsibilities was to identify what are the basic principles and then to develop guidelines for applying these principles, okay? And see how this Belmont report came into being. It was basically 4-day discussions at the Belmont Conference Center at the Smithsonian Institution. That's why Belmont report. And then monthly deliberation over a period of 4 years. That finally resulted in this Belmont report. Issued on April 18th, 1979 by whoever, secretary, etc. And they were given a large terms of reference. Look at the first one. Define the boundaries between research and routine practice. As we go along, as research becomes more and more complex, we are realizing now historically how important it is to delineate these two things, that what cap are you wearing? Are you the doctor here treating the patient with the best possible therapy, or are you the investigator? And what is your relationship? It does become very complex. Risk-benefit assessment and guidelines for selection and the informed consent process. These were the main 4 terms of reference. And in Belmont, and I use this slide several times when I'm teaching, especially undergraduates and postgraduates. What is clinical practice? Belmont has defined this. Interventions designed, where in practice you use interventions which are designed solely to enhance the well-being of the patient and having a reasonable expectation of success, preferably evidence-based. What research is to test a hypothesis using a methodology and then contribute to generalizable knowledge. I think the definitions, if you understand, then the 2 responsibilities also become very clear. Belmont has defined these 3 principles: respect for persons, beneficence, in continuation with beneficence is do no harm, so non-maleficence, and justice. How is this applied is also described. So what do you mean by respect for persons? The autonomy of an individual, the fact that he is an individual and has his own rights. And along with that, they also say that you respect a person, you have to respect a person more if he has diminished autonomy. So your vulnerable populations come up over here. And they describe, as I told you, there are 3 principles are described, and in the latter part of this, 3 applications of how you can fulfill or follow these principles. So the principle of respect for persons or autonomy is described in the informed consent process. And I found the word understood here written. It's not just informed and voluntary, but understood. And when you say that, that's so crucial, because you know, just like Nandini said about Malayalam or Tamil or which language you have, has he understood or not is what is important. I wonder how informed is informed consent. This is something that is debated often. Beneficence is a simpler thing that we can understand. Maximize the benefits and minimize the harm. Now, maximizing benefits is simple, I think, according to me, in designing the trial. But minimizing the harm is more of a responsibility. And maximizing benefits, you know, when we're doing phase 1 studies in normal volunteers with a drug never given before, it raises a lot of issues. And what is the application? Over here is for assessment of risk and benefit is really the application. You do as a research committee member, ethics committee member, you do this ethics versus, risks versus benefits. Now this is an example that I'm giving you. Research in children on a new drug for leukemia. Suppose, why am I saying this? ALL or some sort of leukemia which occurs primarily in children. Or why leukemia, any other disease which occurs only in children. You can't use the medicines, toxic medicines. You can't do a phase 1 in normal volunteers. It's too toxic. So you have to do the phase 1 also in the patient who is suffering. how do you judge? Do you do that research or not? I'm going to leave you with the questions, because there's no way we'll never finish discussion. But imagine weighing the risks and benefits in this case. You have a subject who is vulnerable, who is suffering, who's doubly vulnerable, not only child but also possibly terminally ill. But you have to do research. So you need new drugs because this is possibly a curative medicine. How would you need to think up ways of quantifying the risks, quantifying the benefits, and seeing what methods have been used to protect this individual while doing the research. Leaving you with this question only because this is, I think, this kind of a case illustrates to us how difficult it is to actually implement this risk-benefit analysis. And the last one that Belmont mentions principle is justice, where subjects should be selected fairly to ensure that the benefits and the burdens of research are evenly distributed. And perhaps selection of participants is the application. That means your inclusion-exclusion criteria. Again, a question. I think we mentioned this just a little while ago. A study of a new parenteral antibiotic in patients with septicemia. Is it justified in a government hospital where the patient certainly may agree to participate only because he's getting some treatment, because otherwise government hospitals may not be affording any treatment. They have to buy all the medicines. It happens often in our hospital as well. Should this study be allowed? I'm leaving you with these questions because there are pros and there are cons, and we can discuss this at length. But this is the way we apply it. Your inclusion-exclusion criteria protocol decides your justice. So what are the three principles? Autonomy, application, informed consent. Second principle, beneficence, non-maleficence, again, application risk-benefit analysis through the protocol. And the third is justice, which is selection of participants. Belmont? It's 56 pages, but I've covered it quickly because that is the gist. That is the crux of the whole thing. The most relevant guideline that I have come across, which raises a lot of issues that we face in India, is this one, the Nuffield Council one. This is 200 pages, so it's impossible to discuss it all. But it is something, I think they're giving it to you as a CD. It is something that all of you at some point of time need to go through, if at least a problem occurs. The Nuffield Council on Bioethics, and this is a cartoon which I found somewhere by Morparia. I don't know where I found it, but dominant and non-dominant hemispheres. But that's why this issue has come up. And let me take some examples or some reasons why this whole issue has come up. Maybe some of you all are aware of this, and this goes into the realm of a bit of history as well. As far back as in 1994, the AIDS Clinical Trials Group study 076, first randomized controlled trial was done in US and France to study vertical transmission. It was terminated at the first interim analysis because AZT reduced the incidence of infections. So you stopped the study at interim analysis, and the US Public Health Department said that fine, AZT now should be given to all HIV positive pregnant women. Became the standard of care. But subsequently then, questions started being asked that AZT was very expensive. So there were newer drugs, nevirapine and these others, which came up, and people wanted to do studies to find out whether these new medicines would work. So you needed cheaper treatment. The WHO in 1994 recommended placebo-controlled trials offer the best option. This was 94. An article published in the New England Journal of Medicine, I would recommend you read this. Reviewed at that time, this was in 1997, 18 randomized controlled trials of interventions to produce perinatal at that time were going on, involving 17,000 women. What was interesting was that in the US, whatever studies were going on, the patients in all study groups had unrestricted access to zidovudine, which was a drug then, or antiretroviral, because that was part of their public health program. It's like what we have today in 2007. our patients at a certain, whatever is the recommendation given, they have access to free ART. In India as well, all patients. Then US did. But the same studies, if they were being done in developing countries, the patients were not provided with antiretroviral drugs. It was the test drug versus the placebo. 9 of the 15 studies were funded by the US government, and 1 was funded by the United Nations. Incidentally, in 94, and why was this happening? It was happening because of this concept, like we were discussing, that placebo is absolutely important, because NIH, when they applied for, NIH insisted that you have to have a placebo-controlled trial, and it was the Harvard Public Health Ethics Committee which refused permission, because they felt that this was not ethical. They refused permission, and then the NIH said, okay, maybe you have a point, and do it in comparison to a standard medication. So you see, this is the whole thing this is one of the examples of what is highlighted by this Nuffield, where you should have a balance between this regulatory oversight and subject protections against this scientific advancement and product development. We have interests over here, and these interests should be balanced appropriately, and that is the whole principle, which Marcia Agnell, in again another editorial around the same time, said that our ethical standards should not depend on where the research is performed. The standards have to be the same. Okay? Nuffield in 2000 published, the council had different terms of recommendation, primarily to look at what happens if research is supported by countries but to be done in developing countries. Look at what are the ethical and social implications, and then make recommendations. I'm not going to go into all of these issues because it takes too long, but I think it's important. And again, we have got, and at least our country has, we should set up national priorities for provision of healthcare. That's what the council mentions. If externally sponsored research falls outside this national priority, then there has to be a relevance to it. How does this, it applies to which principle of Belmont, do you think? The last one. Yeah, right, exactly. It applies to justice, that the person should not have to bear the burden unless, if it is a disease that we are going to suffer from, then yes, then the research appears. So we need to have our national priorities, and then if it is outside these national priorities, then the researcher has to justify. If you're doing it in a disease which doesn't occur in this country, then find out why is somebody wanting to do it in India, because it's cheaper, then it's not on. And another point which they re-emphasize is to develop local expertise, not only in provision of healthcare, but also in conduct of research. Nobody should go to a remote area only for that research period of time, give the medical care, do the research, and go out of there. Because you've not developed local capacity in healthcare as well as in research. And 4 principles which are slightly different, slightly modified, are cleared, mentioned over here, that the ethical framework for any proposals should have as its baseline that they want to alleviate suffering, obviously. That is again beneficence to an extent. Show respect for person. But this is important, and this even ICMR mentions, show sensitivity to cultural differences. And if you go through that Nuffield Council, a large number of studies are of African examples, and very beautiful examples they give you. What are the cultural variabilities that occur in specific subgroups of populations? And if you want to do a research project over there, participation of the community is important, and sensitivity in that protocol to cultural differences is important, and of course duty not to exploit the vulnerable is important. The Nuffield Council mentions the need for community consent or an assent from a senior family member. There are a number of ethical issues that revolve around this. I just want to mention one difficulty, and perhaps Dr. Nandini can throw light on this. If we are doing studies on HIV, on an antiretroviral medicine, confidentiality is one of the most important aspects. What happens if I have to take a witness's signature in case of an illiterate participant? Who should be the witness? One, our law says we have to have a witness if you have an illiterate, or do I not take the participant and then am I fulfilling my justice? He's a patient, he may benefit from my medicine. Do I not take him only because he's illiterate? But his wife or husband doesn't know that he's suffering from HIV, so I want to protect his I don't know, there's no answer to my mind. I mean, these are pros and cons, and these are difficulties which, in fact, one of the investigators raised this question to us and one of our ethics committee members and said, what do I do in this case? I haven't found an answer. I'm just putting this here because when it's consent, when it is community consent, and in fact, ICMR has beautifully described this about the participation of the community. They go on to talk about community advisory boards, and I think they have a lot of experience in this as well. So that's something that's worth reading. Standards of care also. Now, who has to define this standard of care is important. Is it correct for me to say that in Gadchiroli district of Maharashtra, where probably even basic neonatal care is not available, do I insist that standard of care should be what is available in Columbia University Medical Center? But then do I fulfill the same, do I say accept Marcia Agnell's specification that the standards should not be different just because you're doing research in Gadchiroli versus doing research in New York? What Nuffield Council says is that define your standards of care in consultation with the people who are working there. So you need to do the researchers. If a researcher comes from Columbia and says, I want to do research in Gadchiroli, then he cannot just walk all over. He has to have a consultation with the local people, and then the research should be conducted either best internationally or at least the minimum available as part of the national public health system. Again, this is nicely, I think, helps us to make decisions. It's not possible, then that research won't be possible. But will doing the research help somebody? Will it benefit the patients? Will it benefit the community? Will you really find some new medication? You want that research done. But it's not practical to say that you want the same standard of care that is available in New York. So then, best international or at least, so HIV drugs, if you have a new or a herbal HIV medication, I'm not going to give, I think personally, you can't have a placebo as a control. Because my national care today is ART for that particular group of patients. It's available. So what is, I'm not talking about international level of medication, I'm talking about what is available in my country. So at least this. And therefore, local ethics committees is important, and therefore again, I think we all congratulate ICMR for this effort of training developing human resources, because you see, local expertise needs to be, you know Indians better than some foreigners. You know the population that is surrounding you, so you will be able to represent, the local ethics committees will be able to represent their rights better than anyone else. Sorry. Yes.
While we were actually revising the 2006 guidelines, we put this phrase, national public health system, because there was, when we made the 2000 guidelines, there was actually discussion on how you interpret that nationally available standards, with HIV in mind. And there were two interpretations. One was that if a person can afford to buy, which can be marketed in India, that person should have that standard. The other one was, like as you said, Gadchiroli somewhere and all that, they neither can afford it, nor it is in the public health system. So the choice should be left. So there was a debate on that. So after seeing this Nuffield Council thing, we put the nationally available drugs in the care in the national
public health system.
Public health system. And this was actually presented by Dr. Vasanta Muthuswamy in one of the national forum, where Dr. Ruth McLean was there. And Ruth McLean was in the advisory committee of this UNAIDS guidelines. And then she said, you will be diluting your own thing, because the moment the foreign sponsors see that, then they will say, okay, India doesn't have this system in all the hospitals, so we can go ahead. using placebo or something like that. So you will be diluting that effect. So before publishing, we removed that thing. It went back to the older one.
I think it's still debatable. I think I personally would like it if this
we have not yet reached a decision on that.
I still feel that if there is an issue where there is some possible exploitation, the local ethics committee ought to have a feel of the patients and they should not be exploited. Again and again, this local ethics committee, it comes down to. I wouldn't be able to be an ethics committee member for research being done in Gadchiroli unless I went there actually and saw what type of patients we're talking about, if I have to protect them. You need to know your type of patients you're trying to protect. I mean, Dr. Vasanta's presentation is there usually where she shows these two twin pillars of protection. One is ethics review and one is informed consent. Ethics review is an important part where you're protecting the patient. You have to put yourself as a protector of that patient. So all these things, you look at it from that point of view, then I think it tends to become a little easier. So I would have liked it, but anyway, we can always, I mean, her point of view was also well taken that we should not be exploited. So it, I think, also illustrates that policymakers have to be so careful because they have to think of all the, and still I'm sure you don't think, some things happen which you never anticipated. These are the collateral effects of collateral damage that occurs or benefits that occur which, with such guidelines, but it's not possible. Therefore, there remain sometimes guidelines. Standards of care, I think that's what we discussed, sorry. Post-trial also is described, and what they say about post-trial is that the protocol has to describe this, and then efforts must be made to secure post-trial, and availability should be there to the whole community. These are some of the issues that are really most relevant to the underprivileged, socially or economically. I'll just give you the example of this, the Gambia hepatitis B. The point is that the research was done in the Gambia, and at the time when it was being done, it was about $60 per course. But the government made efforts to make sure that it was available to the community, and since then, today, it's available at $1 to $2 per course, and it is now routinely introduced on a national basis. So at the time, perhaps it's not possible, but then the government and the NGOs or whoever have to also participate in this to try to make the society as well benefit. So post-trial access is not just that, anti-HIV, for example, do you expect the company to give the medicine for the rest of the life of the patient? Or take an anti-cancer medicine? How long do you expect? I mean, I don't know. Then we were discouraging research altogether. So we have to be balanced. Remember that balance all the time, and realistic. Reviewing ethics committees, they talk about what is important is essential that you have local review. I've mentioned this. And they've also specified that the review should be maybe the hosting country, like US. If the US is sponsoring, they can review all they want. But the local ethics committee also has to. So perhaps that is illustrated in the RCC case. Human resource development is highly emphasized, and training, monitoring their work, training the professionals is what is also described. I'm afraid I've just absolutely taken highly concentrated Nuffield and presented to you the most important points that are mentioned in it. But read it, it helps us in some times when we have difficult situations in our ethics committees, it helps us. ICMR, you had a question? Okay.
Suppose with all the informed consent and all, we are starting with an ART trial, a new drug.
Mm-hmm.
If the participant is adequately educated, he knows I have so much of options, 2 drug, 3 drug, and so and so. And we are going to try a new drug which may or may not have the benefit. If the informed consent is adequately informed, is he or she going to give the consent for that?
A good question you're asking. I think that we may not be able to discuss it all, but the reason why humans participate in research is a whole topic unto itself. There is a study published in the British Medical Journal which says altruism forms a part of why a participant agrees, especially if he's understanding why he's participating in the study. Half the time it could be subclinical levels of inducements that you think you're benefiting because there is no other treatment available. that you think you will get treatments or you will get some free treatment as against having to pay for the treatment. All these things may contribute to the patient's decision. So there are several levels at which he participates. An ideal scene would be total and complete altruism. It may not be realistic.
Madam, you just said that it may be or may not be possible for the people who are doing research on subject to carry on give them the medicine for a lifelong.
Not the investigators, but the company.
The companies. Let's put out a question, ethical justice. You develop a drug based on these subjects and you market it. You draw a huge profit from that. Can't you keep a marginal profit for these people to be continued for the treatment? These are the people who are basic foundation.
Certainly there are patient benefit programs of many multinational companies where they make it available.
This should be made a law because...
Now, making laws, I think Nandini just explained to you, making guidelines and laws is probably the most difficult things. But as an ethics committee member locally, if you genuinely feel that's the only way that this research will go on and the patients will benefit, then you're welcome to suggest it. But remember, you have to have a balance somewhere. It has to be a realistic thing as well as it has to protect the rights of your patient. And believe me, there are programs of companies where at subsidized cost at least it is made available to patients, if not free totally after a period of some time.
Actually, there are examples when the disease is rather rare. Then there are examples of companies providing the drug lifelong. But if you universalize it, suppose diabetes, you know the disease burden, and if a company has to shell out that thing, you can imagine the extent of economic burden on the company itself. So none of the companies will agree for such a clause. And law, as I told you, it's for the greatest good for the greatest number. Now, if law brings in such a clause, then all the companies will go up in arms. Because it will
either they'll go up in arms or they will stop doing research. They'll stop developing drugs because it's impossible for them financially to make this a viable scene. A pharma company is here for profits. That's their job. You as an ethics committee member have your job. Your job is not to stop them. Economic growth is also important. You have governments which sets in laws.
This comes as a priori agreement. That is, before you initiate a project, then you discuss it across the table with the sponsors and come to an agreement. Sometimes it's not agreeable at all, then you don't initiate that. But drug companies as such have multiple sites. In one particular site it may be just 5 patients, 4 or 5 patients. And in cancer trials, some of the companies agree because in cancer you don't expect the patients to last that long. So they do agree. In fact, ethics committees have forced some of these companies to actually supply that particular drug after it is found to be effective.
I think,
naturally.
Let's go to the ICMR guidelines now.
Just a moment, Urmila. I forgot to mention that when government agencies are involved on a large scale, which has a national significance, etc. For example, the HIV preventive vaccine trial. In that, the government is involved, ICMR is involved, NACO is involved, and a non-profit organization is involved. So, for this availability of the drug for the seroconverters has been promised by the non-profit organization, lifelong. So, that is possible only in big projects like that.
We come to our own ICMR guidelines, and I'm going to have to skip through some of these because Nandini has already mentioned it. But I'm going to tell you some of the things that struck me as very important and useful for us. I must go on record to say that as a member working in ethics committees, I find these guidelines extremely useful. At any time there are controversies and doubts, it is so useful to have this book in front of you. You open it to that appropriate page and look, this is what this guideline, this is my guideline, it's Indian. It's not WHO or it's not X and Y and Z. So it's my government's guideline. So it's for me to apply to my patients. What does it say? Let me see. And then you can use this. So I would, again, this is another book you have to read. It's another 200 pages perhaps, but do keep it with you in your ethics committees. Research involving human, this is very interesting, and this comes in the introduction, and I think the introduction is a whole para which is extra to the previous one. Must not violate universally applicable standards. So it's going according to Declaration of Helsinki. But it also says that it should, when on one hand research involving, on the other, a researcher, when it comes to the application of the ethical principles to individual autonomy and informed consent, must consider autonomy versus harmony of the environment. What I think they want to say is that think of your social and cultural environs before you come to a decision. International applicable ethical standards are right, but also look at your own cultural ambience and environment before you take any decision. So what they are trying to emphasize in this is my understanding, is that you must, it has to be a local decision. Another difference, and important this is, and I think it's difficult, is that independent ethics committees functioning outside institutions for researchers who have no institutional attachments, they have recommended. The Schedule Y has recommended this, but ICMR has also said that, so it means, I think this is a, what do you call it, facilitating guideline, because it allows people who are not attached to institutions, but who have the wherewithal to do research, but do not have access to ethics committees. So you want to do it, so you have independent ethics committees. But they also say, and this applies to institutions as well as the independent committees, that they have to work according to SOPs. And to my mind, if this is a guideline which is going to become law, then we all better get down to writing our SOPs and work according to those SOPs. What I want to say here, and it's coming a little later, is that I genuinely wish that we have some kind of quality assurance system for ethics committees, because we see a lot of ethics committee approvals for rubber stamps, as you all know, and you know all the problems that occur. And I think I'll come to it, even in these guidelines it says that there should be a national accreditation. There is a few problematic issues, I think, which may form problems, but I find this very useful. Small institutions should form alliances. That means you can have between 5 institutions, 1 ethics committee, which works around for all 5 smaller institutions. The other point that they say is that small institutions could approach registered independent ethics committees, but it's not clear registered with whom. And this is an issue which we need to look into, because that biomedical authority, yes, but as of today we don't have it. So, okay, Nandini wants to say something?
Yeah, this was a futuristic thing, because the bill was already online. An authority would be formed under this act, and once that comes through, all the ethics committees, private or government, have to register with them. So that was what was meant, but so then that will actually include the others also.
Yeah, so but this is
depends, monsoon session knows. Passes it, then it becomes.
God and our cabinet. God and our cabinet knows. How soon? Nandini can't answer that. She's done all the work. I mean, they have the whole ICMR group, but it'll come when it comes. You can have more than 1 ethics committee. I think this is something that we all need to think of. And many international organizations, Sloan Kettering, MD Anderson's hospital, they have multiple ethics committees. They work under the same ambit, but this is a concept which our ICMR guidelines are mentioning, and I think we need to seriously consider it if you're working in a large this. And I just love this statement that ICMR has made a subcommittee of the main ethics committee, or a separate committee for proposals for undergraduate and postgraduate. There are so many scientific issues in these things that really need to be looked at, which are even, you know, more important than the ethical ones. And this is a lovely thing that administration, we can go to administration and request for. In my institution, in Nair Hospital, we already have a postgraduate committee. So I don't want to go into this, but they have made it in line, the composition and everything, to Schedule Y. And I am happy that ICMR has specified that training for ethics committee members is important, especially in regulatory matters and GCP. Remember to read this, I can't go through it, but ICMR has categorized according to risk involved proposals exempt from review, which can undergo expedited review, and which have to undergo full review. Read it. It's wonderful. It's gold mine. according to me, because for us, when we want to apply it to patients, to our proposals and investigators, and this document, once you say it's an ICMR guideline, it still is acceptable. People will still follow it, saying that, okay, then let me go back. What to submit, there are no issues here, except that there are more than last time. There were 17, this time 21. But there are a few problematic issues, like this collaborative research. International collaborative studies require HMSC and DCGI permission. What is collaborative is not defined. And I would love to know if there can be a definition for this, because the DCGI says perhaps one thing, and whether drug company research requires this HMSC permissions or not. There's a whole area of ambiguity. But remember, for biological material, particularly for genetic material, you have to insist on a material transfer agreement. And this is there in the guidelines, so ask for it. And I'm happy that the guidelines tell us that a statement of conflict of interest, and this should be there even for EC members. Each committee should have its own COI statements. About informed consent, well, it's all there, but the last point I want to specify, assent age is written over here as 7 to 18 years, and I'm happy for this. Again, we have something written which tells you which patients to take assent from. Children, where legal consent is not valid, the drugs controllers law says, Schedule Y says assent is important in children who understand. But ICMR tells us it is above 7 to 18 years. So this is something that's useful. Somebody asked this question about waiver of consent, I remember. Read the ICMR guidelines. They tell you when waiver of consent, when waiver of written consent is possible, when waiver of verbal consent is possible. It's somewhat along the lines of the NIH guidelines. But if you have any doubts, do go to the NIH website. That also gives this more clearly. This is another part that is very beautifully written, and I think I'm going to put this in that research paper of ours as well. For the first time I read any formal guideline giving us something about compensation for research injury, and they've even specified an arbitration committee to be set up by the institution, and I wish most institutions would follow this, so that you can have a case-to-case basis for large protocols of institutions, so that a policy is made. We don't have any in place today. Based on these guidelines, we should have this. Also, compensation for ancillary care. Of course, community benefits are mentioned, and they also go to the extent of saying that how you can give benefits to a community is described. For student projects, I think this is so important that the guides and the institution also have to take efforts to try to make participants have better care in student projects, so that the participants, the research participants, are not purely used for something. For drug trials, I think it's just become very nice and in consonance with DCGI's Schedule Y. I'm not only not touching this also, but placebo is also discussed in great detail in the ICMR guidelines. Read it. But special considerations, issues of partner notification and issues for discordant couples, it's a very tricky problem and a real problem. And even just recently in one of our ethics committee discussions, we had these issues of how do you handle, especially when the female is positive and the male is negative, the social issues that come in these kind of discordant couples, and how do you handle the ethical issues that come up. And I think ICMR does mention it nicely. Very useful statement. Have communication between ethics committees reviewing multicentric studies. How crucial this is, because if one ethics committee has rejected a project on ethical grounds, the sponsor goes to another one. They do ethics committee shopping, and unless we talking to each other and sharing information at some point of time, this is not going to stop. Traditional medicine, I don't have the time, I really don't have the time, but you go through this, the categorization of traditional medicine. I want to congratulate the ICMR also for this, that from herbal remedies, they've gone to title that section as traditional medicines and medicinal plants. So it's now a slightly wider purview, and you know, they have a lot of emphasis on quality, but the 3 categories, what they are and how what level of toxicity is required is very clearly written there. So category 1, it's like conventional medicines. Category 2, you know, for conventional medicines, you can do the reverse pharmacological method. The medicine is described in the traditional medicines, and it is to be used for the same thing that is described in traditional medicines. Over there, the toxicity requirements are fewer, and you can use the reverse pharmacology mode. Category 2 is where the medicine is the same, but you're using it for a new indication. And category 3 is where it's totally new extract. For the last 2 categories, the toxicity requirements are more. And ethics committees will have, because it's not in regulation, remember. So the load is on the ethics committee over here. So please remember this. So category 2 and 3 is like an NCE. The assisted reproduction, stem cell research, it's a brilliant educational tool according to me, and I serve on the National Institute of Research and in Reproductive Health Ethics Committee. And believe me, these projects come to us for review, and with these guidelines now, as even for stem cell we have on the DBT guidelines, they're really useful when you're taking decisions, because the ethical issues that are raised in these, you know, when you're working with embryos and things, are really dicey, and it's very difficult for clear-cut rules and regulations to be made. This is what we are all feeling like now. So I said I have to put this as the last slide. Just one small quote which I like. Research has been called a good business. Many of people say it's a necessity. It is, some people say it's a gamble, a game, but actually Martin Fisher says it is a state of mind. And I wanted to put this quotation at the end because according to me, when we work on ethics committees, it has, all these guidelines need to be internalized, and our state of mind has to be such that we are working professionally, not based on what I feel or what you feel. What do guidelines and codes tell us, and therefore help us to come to decisions? Thank you.